So I am going to start by talking about gender dysphoria and psychosocial factors. And many of you may be familiar with my work, and some people may have signed on because they like the research, and some maybe because they hate the research. And just wanted to mention again, as others had, that this is a controversial topic. All right, so I thought I would start by sharing my values and where I'm coming from and what, which values are really relevant to the work that I do. So first, I am pro-LGBT and I support LGBT people and rights. And I am pro-prioritizing the health and well-being of all people who experience gender dysphoria. And by this, I mean people who have been helped by transition and people who have been harmed by transition. People who have had gender dysphoria that persisted, people who had gender dysphoria that desisted, people who had underlying conditions for their gender dysphoria, and those who had not. And then the final thing I will mention here is that I am pro asking research questions to better understand a condition. So we've talked a bit about rapid onset gender dysphoria, and I'm just going to talk about as well the term ROGD, as well as the hypotheses that were generated from my research. So when I started to explore this topic, I needed a term to use when talking about it, when writing about it. And so I coined the term rapid onset gender dysphoria as a descriptive term to describe a phenomenon where teens and young adults who lacked observable signs of gender dysphoria or gender incongruence during their childhood became gender dysphoric or transgender identified during or after puberty. And so I didn't have to say ROGD. Other people don't have to use the term ROGD. Some might say late onset gender dysphoria in adolescents and young adults. A rose has many names, or a rose by any other name. So it is not a formal diagnosis. The research on this topic is very early. And so I'm just pointing that out there. And I would be remiss if I didn't mention that there are organizations who are strongly opposed to using the term ROGD and are opposed to the concept of ROGD. So what is this hypothesis that I'm talking about? Psychosocial factors in gender dysphoria. And so these I might call the ROGD hypotheses that came from my research. And broadly stated, they are that psychosocial factors such as social influence, maladaptive coping mechanisms, internalized homophobia, trauma, and mental health conditions can cause or contribute to the development of gender dysphoria in some individuals. The reason I've underlined some, and I'm going to point out that it's very, very obvious, but some does not mean all, and some does not mean none. So my research does not apply to all people who have gender dysphoria, and it should not be used to imply that everyone who is gender dysphoric had this kind of experience. My research is one piece of the puzzle in figuring out this topic. So I have little puzzle pieces here. So for example, talking about ROGD, maybe one piece, other people may not have these experiences. And so this does not disprove one or the other. So just in a little bit less polarized example, if I were studying type 2 diabetes, then I would not be implying that everybody has type 2 diabetes. And related to that, if somebody else is studying or finds that individuals have type 1 diabetes, that does not disprove all of the research about type 2 diabetes. All of these areas, all of these experiences, all of this research really are parts of the bigger picture. So why is this so controversial? And I have to say, I have been thinking long and hard about this topic starting from, let's say, the day after my study was published. So this is why I think it's controversial. So currently there is a public debate, there is clinical debate, and I believe people are basically arguing from the positions of two conceptual models for gender dysphoria. And so I'm going to talk right now about a developmental model for gender dysphoria and an innate gender identity model, which you might call gender theory, you might call a gender affirmative model. So from a developmental model, gender dysphoria is may develop in the context of different kinds of cognitive, psychological, social, relationship processes. And the context is important because what you would do to help that patient is different. So for example, someone may become gender dysphoric because they are a young boy who is being bullied for liking ballet dancing, or a teenager who is discovering that she is same-sex attracted and having difficulty accepting herself as lesbian. Gender dysphoria might emerge after the trauma of a rape. And gender dysphoria might emerge in the absence of all of those things. And so the context is important because you would not treat somebody who develops gender dysphoria right after being raped the same way as you would somebody who's had gender dysphoria without any issues. So this is really viewed, gender dysphoria, as something that can have multiple causes, multiple treatments. Now, we don't have clear-cut causes, but just, I'm speaking conceptually. So context is important. Psychological issues, if they coexist with gender dysphoria, could possibly be underlying conditions for gender dysphoria. And I'm talking about the developmental model of gender dysphoria. From the developmental perspective, the desistance research is acknowledged within the strengths and limitations of the research. And as you would imagine, approaches really employ a thorough evaluation. So approaches that are consistent with the developmental model are a developmentally informed biopsychosocial approach, a systems approach, an exploratory approach. And these employ thorough evaluation and a judicious use of medical and surgical transition. So in contrast, there is the innate gender identity model. And this is more of a one cause, one treatment belief. So in this model, it's believed that there is an entity called a gender identity that represents a person's true self. And this gender identity may either match or not match one's biological body. And this is the source of gender dysphoria. And the treatment for this is transition. And because this is more simplified, the context is really not important. Psychological issues are thought not to be underlying conditions. And I'm just going to point out that's really more in practice than what's written. So the way it's written is that psychological issues are unlikely to be underlying or so, if you're thinking about psychological issues, the direction of, you can think that gender dysphoria might cause psychological issues, such as from discrimination and poor treatment, or that psychological issues may be completely unrelated, or you can conceptualize psychological issues as underlying. And so in practice, the suggestion of underlying conditions is often met with hostility and calls that's transphobic. So this is the more extreme version. The desistance research in the innate gender identity model is rejected. And these approaches are approaches that have minimal or even absent evaluation and liberal use of transition. So the informed consent model requires no mental health evaluation before accessing transition. And this is for individuals 18 and older. And it's popular in the United States right now. And I do need to point out that the gender identity affirmative approach, there are people having a debate within this about what is the role of the evaluation, because recently 3 very prominent members of WPATH have spoken out and saying that they are concerned about the lack of evaluation, because there is a trend of clinicians bypassing or considering that the affirmative model means that individuals don't need an evaluation. So, in other words, to say it more succinctly, the priorities for a developmental model are making the correct diagnosis and providing the correct treatment. And from the innate gender identity model, the priority really is quick access to transition. And people in both of these models believe that what they're doing is helping people, but you can understand why there would be a clash of priorities, because the folks from the innate gender identity model will view developmental model as being an unnecessary delay to transition. Transition is believed to be the answer, and delay is seen as harmful. Coming from the developmental model, there is concern that this quick access to transition is failing to diagnose important conditions and providing the wrong treatment to some individuals. So the reason that I believe the developmental model is superior is because there are a lot of outcomes for gender dysphoria and transition. And we know people who have who could be categorized in each of these. And we have research that describes these different outcomes. And so the developmental model accommodates all of these outcomes. Oh, whoops, I'm going to go back. So I just wanted to say, as everybody probably knows, so gender dysphoria may persist, it may desist. Someone may be satisfied with transition. They may only detransition because they are discriminated against, and they might detransition and not regret their transition. But there are people who are dissatisfied with their transitions, who detransition and regret that transition. So moving on, the innate gender identity model, in contrast, only accommodates some of these outcomes. So, so you can see where this information and these individuals and research about these topics challenge this model. And so what I've seen is that there are some behaviors that I think raise some concerns that people might be becoming a little ideological around this topic in this quick transition approach, because typically, you would use data to inform your model and not take the model and take your approach to decide to reject data and people. So, we've seen individuals and groups that deny desisters or really try and discredit detransitioners who regret transition. And we've seen some double standards applied to research. And so personally, I don't think that this approach is compassionate to the people who have these experiences that are not consistent with the affirmative model. And I don't think it's scientific to do so. So in a nutshell, why do I think that my work is so controversial? After thinking long and hard, I think it's because my research it challenges the model and the approach to quick transition. So anyway, so that's really the context, I think. And so switching gears, why did I start to research gender dysphoria? I've talked about this previously, but I noticed in my own community around 2014 that one after the next teenager was starting to identify as transgender, and in numbers much greater than I would expect to see. And these kids turned out to be all from the same friendship group. And so that didn't make sense given what we know about gender dysphoria. Next, I reviewed the scientific literature, finding that, what I'm seeing is not explained by the scientific literature at that point. I reviewed the social media on the topic. I found that teenagers were asking about symptoms and experiences and saying, does this mean I'm trans? They were being told yes, and you should transition right away. And there was a lot of information on social media about how to trick your doctors to get hormones, how to, trick your parents to get you there. And then I searched online to see if anybody else was reporting this. Okay, so globally, there was a lot going on. Starting in 2015 is when gender clinics, specialty gender clinics in Canada and the Netherlands started to publish about their patient demographics. And they noticed that maybe starting in the mid 2000s, that there was an uptick and a really pronounced increase in teenagers seeking care, and an even sharper increase in female teens seeking care. So much so that the sex ratio switched from a population that was predominantly male to one that was predominantly female. Around this time, there started to be recognition of a new type of presentation of gender dysphoria that prior to 2012, late onset gender dysphoria in natal females was relatively absent from the scientific literature. And so this started to be observed more and more. Research coming out of the clinics in Finland and also the United Kingdom showed that teens seeking care had higher psychological and developmental problems. In Finland, they describe perhaps there are additional pathways based on what they are seeing in their patients. And so there has been a tremendous change in the demographics and presentations of patients that occurred rather recently. So why are these changes happening? And so some of the authors of the research documenting these changes suggested some explanations. So could this be decreased stigma, increased visibility and information? And sure, those things would definitely explain increase in numbers, but it doesn't explain why teens in particular, why there's been a change in the sex ratio, and why there is this new presentation, late onset gender dysphoria in natal females. Another proposed explanation is maybe there are sex-based differences in stigma. So if it's harder for males to come out as trans than females, you would see an increase in females. But this doesn't explain why there's a new presentation, why this change in sex ratio was not seen for adults. This seems to be something that is occurring in young people. And so this has really not been researched yet, even though some people will dig in their heels and say, oh, it is definitely stigma, increased visibility, and information, and absolutely nothing else. That's really an overstatement because we don't know yet. And so given that we don't have an explanation that describes all of these changes, and with such big changes, it really could be many different factors contributing to this. Why explore psychosocial factors? So Stella had already mentioned social contagion, peer contagion. Humans are susceptible to being influenced by other human beings in a variety of ways. Adolescents are particularly susceptible to peer influence. And because the driving force of these changes are adolescents seeking care, I think it's important to explore this. There are differences for peer contagion. Female teens are more susceptible to anxiety, depression, disordered eating, and body image issues, while male teens are more susceptible to risk-taking behaviors. Another thing is the pattern of distribution, clusters of individuals announcing a trans identity, the social media content and the dynamics, and the psychological issues. Basically, it would have been irresponsible not to explore psychosocial factors. So I'm going to talk about how I looked into psychosocial factors through the course of 3 different studies. The first study was a study of parents about their gender dysphoric youth. And these parents were recruited from parent support websites as well as snowball sampling. The second study was a study of detransitioners, and they were from the age of 18 to the age of over 60. They were recruited from various sources with efforts to reach communities with different views on transition and detransition. And the third study is a study of desisters and detransitioners aged 18 to 33. And this last one is not an anonymous study. Each of the individuals were screened by video conference. So the third one is not published yet, but the first two they are open access. I am just going to gloss over just the portion that's relevant to this talk. Just wanted to say that. So the purpose of the first one was to collect data about parents' observations of their children who seem to show signs of a sudden or rapid onset of gender dysphoria that began during or after puberty, and to generate some hypotheses about potential contributions to all of these recent changes. The methods I used were methods that have been in existence for decades. Descriptive, exploratory, and online anonymous survey, parent report. Somehow none of these methods have caused outrage until, let's say, 2018. And I recruited by placing information on parent support websites and snowball sampling, which resulted in a fourth parent support site sharing information about the study. And parents were eligible if their child, if they observed that their child had gender dysphoria that began during or after puberty. So there were 256 participants who were mostly female, mostly from the US, but also from the UK, Canada, and elsewhere, mostly white, mostly supported lesbian, gay, and gay rights to legal marriage, and supported the belief that transgender people deserve the same rights as others. The youth described were mostly female, and their mean ages were 14 years of age when their first friend announced a transgender identification, 15 years of age when they announced a transgender identification, and 16 years of age when their parent completed a survey. And 87% of the youth described belonged to a friend group where one or multiple friends became transgender identified in a similar time frame, had an increase in social media use, or both. Based on parent report, none would have met diagnosis for childhood gender dysphoria. And actually, that was an exclusionary factor, that if somebody did, then they were not part of this study, because this is what the focus of the study was. So Stella talked about this a bit. The youth were vulnerable prior to the onset of their gender dysphoria, and they had the belief that transition would solve their problems. I asked parents about the friendship groups and how many friends that were part of the pre-existing friendship group became trans-identified. And so the mean number was 3.5, and which ranged from 2 friends becoming trans-identified to 10 friends becoming trans-identified. I also asked whether the majority of the group became trans-identified, and in more than a third, that was the case. Here we go. So, so I saw some very interesting group dynamics that a substantial number of parents reported that within the friendship group, the friends actively mocked people who were not trans or LGBT, and that when their kid announced that they were trans-identified, their popularity increased. So parents really provided a lot of rich information describing the type of mocking that these kids, engaged in. So I have a few quotes. If they aren't mocking cis people, they're playing pronoun police and mocking people who can't get the pronouns correct. New vocabulary includes cis stupid and cis stupidity. And on the bottom right, this is a really interesting 2 cases that illustrate the power of peers. There were 2 individuals, unrelated, who became trans-identified within their peer groups in high school, had plans to transition the next academic year. Both of these individuals spent the summer away doing something fun, not with their friend group, didn't have access to social media. They made new friends, they had romantic relationships, during that time, they discovered or came to the conclusion that they were not transgender after all. So these kids returned home and were so concerned about facing their friend group that they previously belonged to tell them that they weren't transgender identified, that they asked their parents to help them transfer high schools, and so that they wouldn't have to face the original friend group. And both of these parents were able to do so, and described that these kids were thriving in their new environments. So here's the quote. She thought that none of her friends would understand and they'd think she was a fraud. She wanted to get out of the culture that if you are cis, then you are bad or oppressive or clueless. She was vehement about wanting to get out of the whole scene. So I asked what kind of social media advice these kids had been exposed to, and these are the responses. How to tell if they are transgender, reasons why they should transition right away, that if parents didn't agree to take them for hormones, that they're abusive and transphobic, what to say to a doctor to get hormones faster, that they should use the suicide narrative to convince their parents, and that it's acceptable to lie to doctors to get hormones faster. So, spoiler alert, the detransitioners also saw that kind of advice online. So parents were asked what they think were the most influential sources for their child becoming gender dysphoric. And these sources were YouTube transition videos, Tumblr, in-person friends, online communities. And here are just a few quotes from parents. We feel she was highly influenced by the, if you are even questioning your gender, you are probably transgender. And this other parent reported that there was an online world at the ready to tell her that very normal feelings meant she's in the wrong body. So there were a couple of interesting subgroups, individuals 34 who experienced a sex or gender related trauma shortly before becoming gender dysphoric, 30 youth whose transgender identification seemed to arise in the context of severe psychiatric symptoms, and 8 individuals who, as they assumed a transgender identification, their mental well-being, as reported by their parents, worsened. And then as they dropped the transgender identification, their mental well-being improved. So the hypotheses generated were that this may represent a new development of late-onset gender dysphoria, a new developmental pathway, that social influences can contribute to the development of gender dysphoria, and that maladaptive coping mechanisms may underlie the development of gender dysphoria. So one of my colleagues has said the following, which I think really captures the big picture. So this is from Dr. Roberto D'Angelo. I think that with some ROGD, the individual is already struggling and unhappy due to other issues, and trans is appropriated as a solution to their difficulties. People I've seen often have a fantasy that transitioning would make them into a new person, free of all the old difficulties. I think the social contagion aspect may relate to the availability of the trans narrative as a compelling solution to pain and distress. So the conclusions really are that more research needs to be conducted, that these are emerging hypotheses, and the limitations are the same limitations that are inherent with these methods, even when they're used in research with different conclusions. But parent report, targeted recruitment, convenient samples, anonymous surveys, and cross-sectional research have limitations. So more research is needed, and these hypotheses need to be explored by firsthand accounts of people who experience the gender dysphoria. So the second study is a study of individuals who detransitioned. And for this, I define detransition as having transitioned with medical or surgical methods, and detransition by stopping the medications or having surgery to reduce the changes. And so this is a similar method. However, I collaborated with 2 individuals with personal experience of detransitioning. And this was hugely, hugely helpful to ensure that the survey was clear, that it was relevant to a variety of experiences with detransition, and in helping with the recruitment. And so for this recruitment, we reached out to communities that might favor a quick approach to transition, such as the WPATH listserv, APA, as well as to communities that may not believe that transition is universally beneficial to everybody, like the Detrans forums or actually Facebook groups at that time. So going on, here are my participants. There were 100 individuals age 18 to over 60. They were predominantly female from the US, UK, Canada, Australia, predominantly white, supported lesbian and gay rights to legal marriage. And they first heard about the survey and blogs that covered detransition, other social media. So we evaluated whether individuals had early onset or late onset gender dysphoria by asking at what age they became gender dysphoric, and also did they become gender dysphoric during childhood, at the onset of puberty, during puberty, or later. And so we divided, so early onset was if they began to feel gender dysphoric during childhood. And it was roughly, half and half, early onset and late onset. And 55% of the natal females reported that their gender dysphoria began with puberty or later. And so this is that new presentation that we're talking about. One of the criticisms to the parent report study was that, well, all of these kids must have had early onset gender dysphoria and they just concealed it from their parents. So having these firsthand accounts from people talking about their own gender dysphoria is really helpful, because these individuals said this is when their gender dysphoria started. So there were differences between the female participants and the male participants, and these are the ones that were statistically significant, except for the mean year of detransition. So female participants were younger when they sought transition. They were younger when they decided to detransition, and they were younger at the time of the survey. They had a shorter duration of time that they were transitioned before deciding to detransition, and they transitioned more recently than the males. They were more likely to be exclusively homosexual, and that is based on natal sex. And they are more likely to have experienced a trauma less than 1 year before their gender dysphoria started, and more likely to have felt pressured to transition. So the vast majority of participants took cross-sex hormones. 1/3 of the females had breast or chest surgery, 16% of the males, and 6% had genital surgery. And to detransition, 95% stopped taking cross-sex hormones, 14% started taking hormones that were consistent with their natal sex, and 6% had surgery to reverse the changes from the transition. So the reasons for detransition were diverse, and the most frequently endorsed reason was that the individual's personal definition of male and female changed, and they became comfortable identifying as their birth sex. But people also had concerns about medical complications. They found their mental health did not improve with detransition. They were dissatisfied with physical results. They discovered that their gender dysphoria was caused by something specific, such as trauma or a mental health condition. And some people experienced discrimination and financial barriers. So I analyzed respondents' open text and short and multiple choice to identify different experiences around transition and detransition. And so I'm pointing out where the percentage of individuals that fell into each narrative. Most people did express more than one. So the narratives that are relevant to this talk are that gender dysphoria was caused by trauma or mental health condition, internalized homophobia, social influence, and misogyny. However, I would like to point out that 29% did detransition and experience discrimination and external pressures. Some had the experience of being non-binary, and some people did retransition. So again, these findings are the ones specific to psychosocial factors. But when participants were asked to describe how they feel now about identifying as transgender in the past, more than a third endorsed the option of someone else told me that the feelings I was having meant that I was transgender and I believed them. And so this speaks to the social influence in how individuals interpret their own feelings and experiences to come to a conclusion about themselves. In this population, I did see some of these friend group dynamics described in the parent report study in terms of an increase in popularity when announcing a plan to transition, and groups that mocked people who were not trans-identified. Individuals identified sources that they said encouraged them to believe that transitioning would help them. And 20% indicated that they felt pressured to transition by a person or group of people. And so this included clinicians, partners, friends, and online communities. So here are a few quotes that individuals provided to the "Did you feel pressure to transition?" And I'm only going to highlight a few of these, but one quote is that everyone says that if you feel like a different gender, then you just are that gender and you should transition. And so this is a ideological belief that has become very common and prevalent. So another person wrote, "By the whole of society telling me I was wrong as a lesbian." So this really, we've got a lot of work to do about homophobia. And several individuals wrote about their clinicians. "My gender therapist acted like it transition was a panacea for everything, and my doctor pushed drugs and surgery at every visit." And so if interactions like this can be verified and confirmed, this is really concerning. So other psychological findings, 58% of the population of the participants came to the view that their gender dysphoria was caused by mental health condition or trauma. And more than half had a belief that transitioning delayed or prevented them from addressing underlying conditions. So conclusions, the reasons and experiences around transition and detransition are diverse and include discrimination, concerns about medical complications, difficulty accepting oneself as LGB, coming to the view that their gender dysphoria was caused by a mental health condition or trauma. And a subset of detransitioners provided firsthand accounts that support the ROGD hypotheses. This study, like all studies, has limitations and more research is needed. So we're getting a little short on time, and I could tell you about a study that we conducted and is not published yet. We're still working on writing up the manuscript, but this was a study of individuals 18 to 33 years of age who had desisted or detransitioned. So we operationalized what we were looking for in terms of eligibility as identifying as transgender. So we didn't particularly say gender dysphoria. So participants had to identify as transgender for at least 6 months, and they had to have stopped identifying as transgender more than 6 months ago at the time of the survey. And so this study, actually, after an attempt to sabotage the anonymous collection of data, we had to regroup and make some decisions, and we changed the protocol in a way that all participants needed to be screened by video conference. So we have 78 individuals, predominantly female, but just going on because we're short on time. So we were able to dig a little bit deeper. So where the previous studies were really gathering information about psychosocial factors and asking whether it was relevant, in this study, we actually asked participants to rate how important different factors were for their becoming gender dysphoric and trans-identified, and to rate factors, psychosocial and otherwise, on how important they were to the cessation of their gender dysphoria and relinquishing of a trans identification. So stay tuned. This is a work in progress, but it is very interesting. At least I think so. So what is the state of evidence about the ROGD hypotheses? And if I were to summarize an answer, I would say early, but increasing in strength. So this little picture illustrates sort of a stepwise progression of information. And so the first study was the parent report study. Shortly after that, clinicians wrote letters to the editor noting that they were seeing what was described in the research in their own patient populations. After that, individuals who detransitioned described themselves that the research was consistent with their own experiences of gender dysphoria and transition. The fourth step is the detransitioner research, where individuals provided firsthand accounts of their experiences of psychosocial factors being relevant to their transition and detransition. And then finally is the research in progress about desisters and detransitioners. So in summary of the whole thing, there have been striking changes in the population seeking care for gender dysphoria. Psychosocial factors, including social influence, social contagion, maladaptive coping mechanisms, trauma, psychological issues, internalized homophobia, may be one of several explanations of why these changes are occurring. The relevance of these psychosocial factors has been demonstrated by secondhand and firsthand accounts. And so this emerging theory is completely consistent with the developmental conceptual model of gender dysphoria, but it challenges the innate gender identity model. So I expect there to be continued pushback and debate. Debate is good. And finally, more research is needed. I have a list of references here, which are going to be too small to actually read, but thank you very much for your time.